Midwife Advisory Committee. I am Loretta Melby, the board's executive officer, and I will be running the meeting today as currently we have no chair of this advisory committee. So I will go ahead and establish a quorum. However, they just changed the attendees list. They moved it forward and I wasn't ready for that. Give me 1 second here. Blame it on my technology. There we go. Okay. Jana? And then you guys can introduce yourself when I call on you as well. Jenna?
Oh,
able to
sorry. I
unmute?
thought you said Anna. I'm Jenna
Oh, sorry.
Shantista, nurse midwife and vice chair. Nice
Thank
to see
you.
you all.
Lilith?
Nurse midwife, board member.
Just to be clear, it's advisory committee member.
Advisory committee.
Yep.
On
Board
just
member, we would be in person.
Yes.
Thank you. James?
Byrne, physician committee member.
Thank you. Kenneth?
Same as above. Committee member. Happy to be
And
here.
then looks like Rebecca. Still not in attendance. Okay. And Ruth?
Hi, this is Ruth Milky. Sorry, I was on a phone with labor and delivery. I'm a nurse midwife representative on the advisory committee. Hi, everyone.
Reza?
Reza Pejuhesh, BRN Legal Counsel.
Wonderful. Okay, quorum has been established. We will go ahead and start with general instructions for format of a teleconference meeting. Board moderator?
Good morning. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. We will also be querying the location there in Sacramento, so just be prepared for that. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. Again, we will be asking the public room that we have if there are any comments there as well. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give her a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you will be prompted to unmute. If your question can be answered, the committee will respond accordingly. When making your comment, speak about anything you believe is important for the members to know. Remember, committee members cannot address any item not on the agenda. Items not at the agenda at that moment and items that you would like to add to a future meeting or items that will be discussed later on the agenda will be discussed at their correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting, it is as a result of unmuted microphones, I will mute your microphone automatically. Thank you.
Thank you. Okay, agenda item 3.0 is public comments for items not on the agenda and items for future agenda. And just reminder that this is where the public can make comment, come in and say anything that they need to or want to, but we are not able to have a robust discussion about it if it's not on the future on an agenda. If it is on the agenda, we will refer them to that agenda item. But there is an action that you guys can do is if it is a issue that you would like to have on a future agenda, you guys can discuss that and vote on putting it on a future agenda. So at this moment, board moderator, please open it up to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I have activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment.
This is Reza. One quick thing while we give that a second. I meant to mention this earlier, just a kind of housekeeping thing. I do see all of our committee members on camera, and that's great. Just wanted to remind everyone to keep your cameras on unless you do have like a technical issue or something. That's one of the requirements in order for us to do these remote meetings. So just a reminder, and again, thank you.
Oh, Board EO Melby, there are no public requests for comments on the WebEx. Do we have any public requests for comments there in Sacramento?
To get off mute. No, currently we do not have any public members present here in Sacramento. If that changes, I will let you know.
Perfect. Thank you. Board EO Melby, would you like me to close this window?
Yes, please. Thank you. Okay, agenda item 4.0 is review and vote on whether to approve the previous meeting minutes. Those meeting minutes are in the packet that is posted to the web, and hopefully you guys have had a chance to review them. It does start on page 6 of the pack. And at this point, if there's no edits, we can get a motion to approve.
Approve. Second.
Okay, so the first was James and the second was Jenna. Is that correct?
Yes.
Okay, and if we could just try to make sure that we say our name before we do the motion, as this is a virtual platform and some people will not know who is speaking when that occurs. So we do have a first and a second on a motion to accept the meeting minutes. At this point, we'll go out to public comment for discussion from the public on the meeting minutes, if there's any. Thank you.
Public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you or cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public. Type in, I would like to make a comment. Board EO Melby, there are no public requests for comments on the WebEx. BRN Sacramento has stated there are no public members yet in Sacramento, and we will be notified. Would you like me to close this window?
Yes, please. Thank you. So we'll move on to agenda item 5.0.
Could we do a vote?
Sorry, we have to do a vote. Thank you, Reza. Okay, we'll do roll call vote. Let me pull up my list. I now have it up and ready for me this time. So, okay, Jenna. James.
Yes.
Rebecca. Not here. Ruth. Anna.
Approve.
Okay. The motion does move. Thank you, Reza, for putting my head back on straight. We'll move on to 5.0. Okay, 5.0 is discussion and possible action regarding election of chair and possible vice chair. The only way it would be possible vice chair is if she decides to step up to chair, but if not, her position can stay as vice chair. So at this point, excuse me, Mary Kay did resign. She was the chair of our committee here. And so we are looking for a new chair. At this point, I will open it up and see if anybody has any elections. You can put yourself forward as well, or you can respectfully ask somebody else to chair if that is what you guys want to do. And then we will wait to see if the person that is been appointed or suggested to be appointed is willing to accept it. So we'll open it up to the committee members here for discussion for the chair position first.
This is Ruth. I would put forward Jenna Shaw Bautista. I think she had some interest initially in that, and she now has some history with this committee. So that would be whom I would put forward. Jenna?
I would be willing to do it, and I would love a vice. And Ruth, I think you would make an excellent.
I am all about vices. So yeah. At least
Let's make sure that's on the record, that Ruth
Good
is all
vices.
about vices.
Yes,
No.
good vices. Yes, for the public, good vices. Yes.
There we go. Is there any other suggestions from the committee? Okay, it looks like we have put forward a chair of Jenna Shaw Bautista and a vice chair of Ruth Milkey. If there is no further discussions, we will go out. I would need a first and a second. And Jen and Ruth, you can be first and second if you want to. You can make the motion to appoint yourself and the vice chair. If nobody else wants to step up and do that, it's perfectly okay.
I would make the motion that these nominees be accepted.
Okay, so that is Ruth as the
second.
first.
Move
James is the
This is
second.
James, move the second.
Sounds great. Thank you. We'll go out to public comment.
The comment now, please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board EO Melby, there are no public requests for comments. We still have nobody in Sacramento. Would you like me to close this one?
Yes, please. And then I'll do a roll call vote.
Thank you.
Jenna? If you can.
Yeah, sorry.
Thank you. Perfect. James? Rebecca is not here. Sorry, Ruth?
Aye.
Kenneth? Perfect. We'll accept it and we'll move on to agenda item 6.0. Okay, this is a report from our 4 NMAC. And you know what? I forgot you, Lilith. I'm so sorry.
It's okay.
Do you want to vote to accept your chair and vice chair?
I approve.
I know that you weren't here for minutes, so I purposely skipped that one, but I apologize for that. Okay, and so item 6.0 is report from the NMAC subcommittees. That we have 4 of them, one on public engagement and website, one on nurse midwifery scope of practice, and one on regulations, and one on nurse midwifery education. On our website, we do have those listed. Public engagement was Mary Phillips, so we will not be able to report off on that as she is no longer in attendance, and I don't believe we received a report. Nurse midwifery scope of practice is Jenna Shaw Bautista and Ruth Milkey. Do you guys have a report?
We do not.
Okay, so then we will also touch bases with you offline, see if there's any assistance that you guys might need from us, and make sure that we have some subcommittee meetings set so that we can assist you in any way possible. Okay, regulations is Dr. Byrne. James. any updates from you?
Yeah, just as most of you are aware, SB 667 passed and was signed into law last October. That provides nurse midwives with the ability to perform common gynecological care. So again, really long overdue and now in place. That was the only thing of note. One of the components of our last meeting was Reza had brought up that the DCA regulation attorney or other staff oftentimes will get information, but regarding upcoming or pending early in the legislative process bills. I was going to request if it's possible for myself to receive information from DCA staff, BRN staff, about things that are
Yes.
coming up. I
Absolutely.
think that'd help me more than I do look through websites and check what's going on, but realize the insider scoop would help.
Yeah, I'll actually have Marissa Clark, who is on with us. She is our chief of legislation. She'll reach out to you directly. There is websites that you can go on, excuse me, leginfo.legislator.ca.gov. It is a public site. Anybody can go on it. You could set up notifications for keywords. And so like typically we put in nurse, registered nursing, board of registered nursing. And any time that a bill is introduced with those words involved, you will get an email that says bill introduced and you can choose to look at them. But we'll also, Marissa does an amazing job at tracking and such. And so we can make sure that we can get that communication out to you as well as part of your subcommittee work. With the passing of SB 667 last year, is there anything that you looked through that where you saw that there might need to be some regulatory clarification?
Not from my end.
Okay.
And this is where others, either public at large who are attending these meetings or some of our other advisory group members might have additional inside awareness of gaps. So that kind of feedback would be fantastic.
Sounds great. So if there's any discussion here around this, we'd love to hear from you. I will, at the end of this report, I believe there's one more committee after this. We will open up to public comment, see if we have anything further there. But then also, James, I would like to set up a meeting with you, Marissa Clark, the chief of Ledge, myself, and help you through with this subcommittee as well, so that you are supported in a little more direction there. And then Reza typically attends also.
Okay, this is Reza. Sorry to interrupt. I was just going to add, just a reminder again, under Bagley-Keene, you all are kind of confined outside of these meetings to only talk amongst your subcommittees. But if you had feedback on, say, a topic that is not your subcommittee, but is a different subcommittee, you can talk about that kind of feedback in these public meetings. So these would be the forum for you to, kind of branch out of your subcommittee if you happen to have something you want to, tell James about regulations or recommendation or something like that. For example, an idea regarding regulations. These public meetings are your forum to do that, to kind of cross over. So hope that made sense. If you have any questions, please let me know.
I don't know if it's appropriate to jump in here, but I had a sort of similar request on behalf of Ruth and I for Education Subcommittee. And as you mentioned, Loretta, we would love some more kind of guidance from you, but we had also been charged with identifying some goals. And one of them was how to more proactively identify issues. If things flowed straight to us, which it sounds like they're not really going to, nor would it be appropriate for us to respond directly. But one of the things that we discussed in brainstorming how to proactively identify issues was to perhaps have staff report on any issues that have come up since the last meeting and what, if any, subcommittee they were directed to, which I think would be helpful going forward for not just our subcommittee, but all of them. That would be helpful. And I realized that although Ruth and I didn't talk about this, there is I'll leave it at that, actually. I'll need to confer with her before I say anything else.
update, because coming away from our last meeting, I thought it was, appropriately, Razor, you gave us guidance regarding some of the siloed nature. And I think all of us, by our own individual nature, are very collaborative and used to like just having conversations and trying to advance things forward. So knowing that Marissa could reach out and we could have those kind of conversations in this forum is great. One other thing on the report, Hillary had been the second member of this group. I don't know if both the process or if there's any interest of any of the current advisory group members to join me in keeping an eye on regulations. So Loretta, is there a process for another subgroup member?
So we can actually do some action today, if that's something that you guys would like to do. If Lilith would like to be a part of it, we know that you're not on a specific subcommittee, but there is some definite need for assistance. James does have a vacant opening if you're interested in regulations and legislation. And then public engagement and website was vacated by Mary Phillips. So if you are interested in either of those, we could definitely have a conversation around that.
Okay. Yeah, I don't know if we're having that conversation later, or I can just say now that I would be open to being on the regulation subcommittee.
Fantastic. If the subcommittee is okay with that, we'll actually get a vote on that after we go ahead and do a report out for the nurse midwifery education aspect. And so Rebecca and Kenneth, if you guys have anything to share on the nurse midwifery education, other than what you had already done just a few seconds ago, you don't have to repeat that. And I know that Rebecca's out, so it'd be, it's all on you.
I didn't do much about it, but I will be much more proactive between now and then.
No worries. We'll reach out too and just kind of keep a pulse on things as we go forward. We did not do that as much this last quarter, so we'll definitely make sure to do that as well. And I believe I received just a message that said that Macaulay is already on this. She is sending emails, and Marissa was already on it. So James, you should have an email from her as well. So things are moving. So thank you very much. So at this point, a motion can be made that Lilith join as the second member of regulations. If we can get a first and a second on that.
I'd like to make a motion to have Lilith join regulations.
Okay, and that's James. Do we have a second?
Second.
Sounds great. Thank you. And then the other aspect of the report outs, Reza, do we need to make a motion to accept the reports, or are we good with just this motion for this agenda item? I saw the head shake no, so I can take that as a no. Perfect. Thank you, guys. We'll go out to public comment.
The comment now, please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public. Type in, "I would like to make a comment." Board EO Melby, there are no public requests for comments in the WebEx. There are no public requests for comments in Sacramento. Would you like me to close this window?
Yes, please. Thank you.
Thank you.
And then just a consideration before we go out to public comment, take a roll call vote. Sorry. We did have the subcommittee with Mary Kay on it, and she is no longer on that subcommittee. if that's a subcommittee that you guys want to continue, we can absolutely continue that. And when we do have new appointees come in, they can fill that role. But you guys can also consider that going forward, you may want to do a different subcommittee. You might not have a subcommittee that's a member that is interested on public engagement or that is interested in website cleanup, although we highly recommend you continue that one part because our website can absolutely use some updating. But just kind of food for thought in the back of your head as when a new member comes forward, if you wanted to change up the subcommittees at any time, have a new focus, we can add that to an agenda item, and we can always change that if you find that their current subcommittees are not as effective as you'd like them to be. Okay, so we'll go to a roll call vote at this point. And so at that point, we'll start with James. You can just accept the motion.
Yeah, that
To
was, sorry,
appoint-
that was an I as in, yeah, I.
Oh,
as
sorry, I did
opposed to
not
nay.
hear it. I apologize.
No,
Jenna,
Sorry
I
for cutting
skipped
off.
you.
So yes, approve.
Thank you. Jenna, I skipped you. I'm sorry.
Aye.
Thank you. Ruth? And Kenneth?
Approve.
And Lilith?
Approve.
Thank you so much. We'll move on to agenda item 7.0. Okay, 7.0 is our last agenda item for today, but it should have a robust discussion. So we did add some time on this. So with the implementation of SB 1237, with the removal of standardized procedures being required for the nurse midwives, and for the passing of AB 890, where standardized procedures are not required for nurse practitioners, we took a look at our disciplinary guidelines, and we realized that if a advanced practice RN is placed on probation and they have an independent practice, that we would need some provisions to allow them to continue to work in their respective fields. So what ends up being an issue at this point is prior with when you guys were both working under standardized procedures, there was supervision that was required. Potentially, if you guys worked in clinics, it would be easier to have supervision if there was another nurse midwife that you worked with or another nurse practitioner that you guys worked with. And going forward, this is an area that needed to be adjusted so that we can ensure that nurses, advanced practice nurses that was placed on probation can still continue in their business. So at this point, we did get together, we did some suggested language. When I was meeting with the chief of Ledge yesterday, she said something brilliant, as she always does. And so I'll have her come off mute and share that. And she will let you know kind of how this came about, what has been done, and open it up for further engagement and discussion on the suggested regulatory language. Marissa.
Everyone, I don't know if it was brilliant, but I was just kind of walking her through how we got to this point to make sure that it's clear that this is not final language. This topic had come up before, as Lori had discussed, and so what I did is I went back and just started kind of researching other areas in similar boards where this had been addressed, like mainly the medical board, obviously, and was trying to find out some of their language and then pulled over and then started to tweak it so it was more appropriate from a nursing perspective. Met with our enforcement folks, met with our legal counsel, and actually ran it by the Attorney General's office just for their kind of input. And all this really is something for you all to react to. So in drafting language, sometimes it's really hard to get to that starting point. So I wanted to put a starting point there so that you all could kind of look at it and say, yes, no, we think this, we want more of this. So I just wanted to make clear this isn't the final language. It's really a chance for you all to weigh in on it. But we wanted something there that you could weigh in on just to make it a little bit easier to kind of get everyone's head in the same frame and have the basic framework that regulatory language typically takes. So I hope that helps.
Okay, so you guys will find on page 24 of your packet, there is some suggested language to help facilitate this. And in the underlined is all language that has been added. The black text with no underline is current language. And so that would not be adjusted or not need to be changed at all. So the underline starts at section E, and it talks about the independent practitioner. And there's a couple sections on there. You guys would take a second to review. And then I can kind of explain the probationary process from the BRN point of view so you guys have an understanding of the current process. Shannon is here as well, and she can kind of lead us through the general aspect of it. At a couple points throughout the career working with BRN, I was the nursing education consultant that helped with employment placements. And so when you're doing employment placements, the probationer will send their prospective employer information to their probation monitor. That information is then more information is gathered, like an org chart, job descriptions, what are the requirements for duty, and then that is sent over to the nursing education consultant, who then reviews all of that and looks at why the person is on probation and what are some of the mitigating factors, if there are any, and what is the public risk. And we follow the court orders that come through this as well. And so when you look at it, there are currently 3 different levels of supervision, which is maximum, moderate, and minimal. Maximum supervision is, and these are the same for all probationers, right? Maximum supervision is when you report to work, and if you're a 12-hour shift, you have a one-on-one for that entire 12 hours. You go to lunches together, you go to breaks together. There is not a time that you are engaging in patient care where you do not have a person of equal licensure or higher with you and monitoring you, so that there is a very reduced possibility of any public harm occurring if there was a need for that. With moderate supervision, it's half your shift. So if you're a 12-hour shift or an 8-hour shift, it would be 6 hours or 4 hours that you have somebody with you available for consultation, and just kind of touching bases and keeping an eye on things as you go and you progress through your probation. There is, you are allowed to take lunches by yourself, breaks by yourself. There are also narcotic provisions that could be added or removed depending on what the scope is for the role of your position, whether or not there's narcotics in the facility, and that can be addressed, and whether or not you have a need to actually administer narcotics. And if it's a practice violation or some sort of issue that was not like diversion related or we're at risk for narcotics, and we could grant full access and administration to narcotics as well to the scope of your licensure. And then third is minimal supervision. And typically this comes when you're about ready to get off probation, and it gives you as close to a real life kind of non-probationary experience as possible. And that is where we just check in with you. And I say we, but not me. The worksite monitor that is working with you checks in twice a shift. There is additional provisions if someone is working in home health to allow for that to work. And so in that spirit, where there's additional provisions to help with home health, it was looked at that we may need additional provisions to help you guys continue to work as an independent practitioner. So at that point, I will open it up to discussion. Shannon Johnson is here and ready and available for you. And she is our chief of enforcement and the guru with everything that comes for disciplinary guidelines.
Well, I'll jump in with my initial reactions if we want to get it started. I think it makes a lot of sense to have something specific to folks that are working in the normal scope in an independent fashion. That said, I'm not really sure who those people are, and I suspect that they are not necessarily doing shift work. And with my manager hat on, I also would encourage us to move away from the shift mention, especially since they can be variable in length, and instead consider language like checking in every 4 hours or something really specific that, but also generalizable to all practice settings. Because I feel like, at least in my area, the folks who fall into this practice category are increasingly going to be people practicing birth in community settings and or hopefully obtaining privileges for normal birth in a community hospital, but they might go back and forth. And then also with my manager hat, I was just actually a little bit surprised because essentially none of the levels of supervision require direct observation of patient care. And they all seem super minimal. I didn't realize that this was the standard, but basically in a typical clinic setting, unless you're in a really small clinic, you could just have your normal workday and meet almost all of these criteria with nothing extra. Because there's nothing about observing care, reviewing charts, or doing like kind of that level of review. So
that is also,
but those are my observations.
Yeah. So just to be clear, this is a very narrowed scope of the disciplinary guidelines. It is one small section that's being addressed. There are in other areas of the disciplinary guidelines where we do address chart audits, reviews. We also have a part of the probation where we can we find out what kind of, like, maybe if they have a Pyxis or an Omnicell, what kind of reporting goes through, what kind of pharmacy reviews as well. So that is part of it. And when you're doing the maximum supervision, if that is something that is currently in practice, right? That is maximum supervision. They go into the patient's room with you. They go out of the patient's room with you. They shadow you 100%. There is not a time that you are alone performing any of your job duties, no matter what they are. And so that absolutely is incredibly restrictive. And we do have that ability to request that. One just wrote, and I see your hand there, James, I promise. I just wanted to adjust Jenna's before we move to that really quick. When you're looking at page 24 on maximum, moderate, and minimum with the suggested language, it doesn't talk about shift work. The reason that I brought up shift work is that is what we are currently working with, which is why it's important to kind of add this section to regulations. Understanding that this section is listed as independent practitioner. It is not scope specific. So your clinical nurse specialist, your nurse midwife, your certified registered nurse anesthetist, and your nurse practitioner will be utilizing this section as well. It is for everybody. And so when you're looking,
bottom does refer to each shift worked.
It says setting an independent setting at all times. It says the individual providing supervision is present in the independent setting at all time. And then it says the individual
just
providing
in terms
supervision.
of the hours, the very final sentence on page 24. And it's very reassuring. I do see that in the maximum definition that the individual providing supervision and or collaboration is present in the patient care area. I see that up above under the definition of maximum. And I would just maybe make a suggestion to really specify like observing or directly supervising patient care, just from personal experience at our little local regional hospital. That has been key in understanding the difference.
Okay, that is language that is current in our disciplinary guidelines. And so that was not language that we had suggested for amendment at this point. But I do see
underlined part down below where it specifies the maximum. Is that new language there?
Yeah, that's the new language, and that's specific for independent practitioners. So I'm not sure if I'm seeing the same language.
So you're both correct. So the maximum, moderate, minimum was already in the existing under probation 8. And then the E is that new area, and we pull down that same maximum, moderate, minimum, and the minimum both references that shift, as you mentioned, and then also has that direct patient care that I think you're saying, because you need to go a little bit more specific. So it would be, I think what we want to consider is it would be creating different language for the independent practitioner than would already be there for the other RNs. And if that would create any, conflict, I don't know, that would be for everyone to discuss. So it's existing language we wouldn't be touching, and then the new language that mirrors the existing language that we would be touching, if that helps.
Yeah. And then I know that James was next, but Lilith, if this is around the same topic, and James, it's around the same topic, I'd like to kind of explore more on this specific kind of discussion that Jenna has, and then we'll go on to additional ones if there are more sections that we'd like to look at.
Raise hand thing up for some reason. I want to
No,
be
that's okay. We hear you, Ruth.
queue. Okay, thanks.
Ruth, were you going to go? Or
This
feel free.
is okay. So I am putting on my former business owner hat here.
Yeah, that's what I was going to say.
I'm a midwife in a practice that I'm on probation. And my first question that I have two-part question. How long typically is probation, or what is the range? That's one. And then two, I'm in my own little clinic and I have to find somebody, let's say even with, I don't know, minimum, something like that. What if that person will only do it if I pay them? And that seems like that would be a little conflict of interest. I'm paying somebody to supervise me, i.e. to pass me. So I don't know if you've thought about that whole relationship with the supervising person. I would love the thoughts on those two things.
Yeah, definitely. I know that was been discussed, and I know that this, when you're looking at this from like being used within the med board, and osteopathic board, other practitioners that have an independent practice that utilize disciplinary guidelines, and have to have some supervision. I have heard that it is paid. Shannon, if you can jump in and give a confirmation on that. I'm not the expert of that area, but I do believe they are paid or contracted in for this.
And that is language in their guidelines for MedBoard. For us, that is not in our language. However, on our attestations that go out to the employer, it states that they are affirming that they do not have a familial relationship, personal relationship, or financial relationship with the probationer, because it would be a conflict of interest, because they do have to provide us reports as to the supervision level assigned, maximum, moderate, minimum is being followed. If it is being followed, it's basically a job review that we get on a monthly basis, normally in the beginning every month from that worksite monitor. It's a little different
so
than
how are they getting paid? Who's paying them?
They don't get paid.
Oh, okay. Interesting. But yet they're assuming some type of liability because their name would be in records and things like that.
So Shannon, you said the med board does allow for payment. Is that correct?
Well, I believe it's something along the lines of the physician is responsible for hiring their own worksite monitor or obtaining their own worksite monitor. That is not the case with BRN. They don't have to obtain them, and we go right to the source. We don't go through the nurse, because we want to ensure that the employment is exactly what is being stated. The monitoring is exactly what's being stated. We do have, and I hate to say this, but we do have nurses that will try to write up their own org charts and their own duty statements and provide them to the board. So we don't accept anything directly from the nurse. It's from the employer. That way we can ensure that those documents are accurate. We obtain attestations. And then the reporting goes right from the employer to the monitor at the board. Nothing goes through the nurse.
But Shannon, if a midwife is an independent practice, she or he is their employer.
They're self-employed.
Determine based on that type of setting, and especially if the violation occurred while they were working as a midwife, we would want to ensure that they work as a midwife and they are monitored as a midwife and have the appropriate supervision. So if they're going to different hospitals, they may have to find more than one worksite monitor. So if they're going to different locations, they may need to find a physician oversight or someone that's appropriate to monitor them at each location. However, it's difficult when they're in the home and they're on their own. So
gonna be impossible.
Yeah, so exactly.
Have you all thought about some type of template letter that would go to a monitor that would describe based on the minimum, maximum, or whatever medium, kind of, so that would be an easy document to distribute as a, I don't know.
You mean an explanation of what those three
Yeah, I mean,
levels
I wouldn't
are?
do it if somebody off the cuff said, hey, will you da-da-da? I would like to see something kind of formal, that this is, you know, approved process, that there's something, some guidelines.
Yes, well, the explanation is just within the decision and order on the three. The nurse is responsible for providing that to the employer. And then once we obtain the employer information, our nurse in-house for enforcement, she contacts the employer, has the conversation on what the setting is like, what the scope is going to be like. You know, if standardized procedures are needed, are they in place? We obtain those, and then explains all of the supervision requirements. So that conversation is had one-on-one with that employer, so they're aware of what's going to be expected of them, and all the expectations are also listed within the attestations.
So again, that is fine if there actually is an employer that's different than the nurse midwife. So I think there has to be some thinking about the person that truly is in solo practice, and they're, you know, really, they're it.
Agreed.
Yes,
and what
that's
does
why
the liability question look like? Would the nurse midwife who's being investigated have to insure her monitor to participate in patient care? Would a confidentiality agreement suffice? What
So
if
James has his hand James has his hand up, so I do want to give him a chance, and he may have some understanding with this coming from the physician point of view. And that is why all of these questions are wonderful. That is why we added E, because every one of the disciplinary guidelines and the process that Shannon was referring to is for the non-independent practitioner, right? That is, these guidelines are for RNs. They're for nurse midwives when you guys were working under standardized procedure. There's for nurse practitioners when there was a supervision requirement and they were under standardized procedures. So now we know that we have to have an additional section that addresses independent practice, that business owner specifically, which is the language that we're talking about today. So James?
So my ultimate focus is similar to the other thoughts brought up, but I don't know how to get there without some context questions. And they're really pretty simple. So the first is, this is important for equity, is this language modeled what's in place for other independent practitioners, such as dentists or physicians?
Marissa did take
more stringent.
No, so we did look at this from the med board and osteopathic board. We did a look on that. Marissa can probably speak to that a little bit more. She might have like a section specifically it came from, but that was our starting point.
Yeah, no, it's more, again, to evaluate how this language looks. I want to make sure it's equitable. So this is relatively similar to what's in place for other. I think culturally we're shifting from having been non-independent providers to independent providers. And so is this similar to the language for independent practitioners in other professions?
Yes, it is.
Healthcare specifically. Okay. So if that's the case, yeah.
Oh, sorry, go ahead.
Go.
Okay. I was just going to, I did start with the medical board language, look through that because they have a section on solo practice prohibition, because they're kind of looking from the other way, right? They're assuming you're independent and then going not independent, whereas we're coming out of the non-independence. But what I also look for is trying to balance equitableness with the other independent practitioners, but also equitableness in how we treat our existing licensees that may or may not be an independent practice. I was trying to walk that line, not in that you treat them the exact same, but in like the expectations of the monitoring, try not to make it way more loose or way more stringent than we are for other licensees if they're in, unless that's something that people think is desired and is needed. I was trying to kind of balance those two, if that helps.
No, that does. Thank you so much. So with that, and again, I have a lot of the same questions brought up about in the room and the percentage of times, but the second context question, can you give us examples of things that would, examples of cases or issues that would either be minimal, moderate, or max? Because I'm focusing on the max. I think other people might be as well. But what would in real life be examples of something that's minimum, moderate, and max?
So I can probably go over maximum pretty easily. There were incidences while I was working as a nursing education consultant doing the job placements where you would get a nurse practitioner or a nurse anesthetist or a nurse midwife or that had some practice violations that were definitely affecting patients and potentially resulted in death. And so then at that point, you, in order to get them back working without having any further risk to the public, you would do a maximum supervision. One of them was an example would be working out of their scope of practice where they were trained in one area, but they were practicing in a different area and they were not competent. They missed basic assessments. They missed basic kind of history, everything that could have been done, and an infant passed. And that was with a nurse practitioner. So then we had a nurse practitioner that was not trained as a pediatric nurse practitioner, working in the realm of a pediatric nurse practitioner, missed on several occasions some assessment data that would have shown that the child was in rapid decline, and the child did ultimately pass away. Complete miss on that nurse practitioner. Additional ones that have come across is we've had nurse anesthetists who are in the operating room with the patient, the surgery is going on, and they leave the patient care area, yet the patient is under anesthesia. And there is no anesthetist at the bedside. They have left the OR completely. So that is definitely a high risk. And you would have that person on maximum supervision. Other examples that have come forward where you'll have maximum supervision if there is any other like potential patient abuse. Maybe there was some assault and battery that occurred where that became problematic. Sometimes there was unprofessional boundary crossing where they ended up having relationships with their patients in a sexual nature, and you would have maximum supervision, stuff on that, if they were able to kind of continue in their practice. And so there's definitely a lot of examples that could come forward for maximum supervision. When you go to moderate supervision, sometimes I would see that more frequently, say they were disciplined out of state, and then they did not complete their probation there, and then endorsed into our state. And then we would pick up their discipline, and then because they've done a lot of it already, we've done the assessment, we've heard, we've seen everything like that, we could maybe drop them down to a moderate supervision. Some of the other moderate supervisions ones I've seen is when the prescribing is not consistent to community standards. Maybe they're over prescribing certain medications, maybe some Schedule IIs, etc. You can do a quick audit with that. So having them come into follow you into all of your patient care areas, that wasn't really the issue. It was that we needed to do some more monitoring of records and making sure that the prescribing is on the up and up versus not. So that could be an example of moderate supervision. Maybe another moderate supervision could be if there was just a near miss. You know, if something had happened, there was some negligence, there was some gross incompetence, and they just needed some additional training to get them back in. So we have them doing some CEUs. They're responsive, they're going through the process, but we do need to ensure that that training stuck and that there was no additional risk to the patient population. And so then we would do some check-ins with that. Minimal supervision, a lot of times we saw them if that was an issue that occurred outside of the workplace. You know, was there a domestic violence issue that occurred outside of the workplace? Was there a DUI that occurred outside of the workplace that wasn't involved with actual patient care? So at that point, it is noticed that it is it does touch on your nursing practice. It does show that there might be some anger management issues. There might be some addictive issues, that your thought process is altered in some way. And so at that point, you could do a minimum supervision just to do those quick checks, just to make sure that, you know, they're getting their assistance, they're attending meetings, they're doing some anger management classes, you know, something to that effect, so that again, the patient safety, the public safety is upheld, but it's not an egregious occurrence where your patients that you're caring for are potentially at immediate risk, right? And so you can drop that down. Now, earlier the question is how long probation is. Typically, it's 3 years. It can be extended out depending on various provisions, but it's typically a 3-year process. And what we would like to see is a transition from your highest supervision, whether you come in at moderate or you come in at maximum, to the minimal supervision towards the end of that probationary period, so that we have as close to what it would be with you guys off probation, not you guys, but the independent practitioner off probation, so that we can see during the assessment that the worksite monitor still has good reports, that with that freedom, that, you know, everything is still going well with the chart audits and such. So hopefully that helped explain.
Sounds like maximum is limited to things where there's clear and present danger to human beings.
Correct.
And so drug diversion or drug use in a work setting, or some of the clinical things. Hopefully that's very rare, but okay. And so more of these would be toward moderate and minimum. And now my questions are more in line with what others were saying. Present in an independent setting is the language used for both 1 and 2. Just when it comes to supervising residents, for example, supervision is defined as either being in-room supervision or on-premises supervision, or readily available electronically. Are there any of those nuances here? I'd imagine for number 1, given your context, that would be on-site, in-room. But for moderate and minimal, is there any sense of what definition of present means?
Not at this point, but that is something we can add in. Absolutely. That's why we bring the sample language forward and get the suggestions from you guys.
Yeah, that was my suggestion, to clarify that too. And if there's additionally a simultaneous chart review process, then I could see supporting some readily available on site, but not in the room, at least for minimum, depending on, you know, what the offense is. But I agree, this is not the kind of language we typically see in settings, either clinical or educational. It's usually a little more directive.
Would you mind just repeating that? I just want to make sure I'm getting it down accurately when we go back and amend.
Yeah, I was just saying, clinically and in education, we tend to use language like Dr. Byrne was saying, either directly supervising patient care or present in the clinical setting, which means not in the patient room, or readily available, which could be off-site and, you know, readily available for a consult electronically, reviewing the chart, could come in an urgent situation, but not on site. So those are kind of the 3 levels that we usually talk about with learners and with onboarding of new folks. So I would suggest using some of that language mirrored, and maybe considering, like the minimum already says, they're directly communicating at least twice during the shift. Maybe we're going to say every couple hours, since we don't know if they're really on shift work, but we could say from off-site or in the patient care setting, not in the patient room, you know, somehow really specifying some lesser level of supervision, potentially for number 3 minimum than maximum or even moderate. And just one more thing I'll throw out there before we take this to public comment. I got 2 texts from community members that they were trying to weigh in on earlier topics, but the chat function isn't working, so they can't type in that they want to speak. So I don't know if we could work on that before the next public comment section, FYI.
Open when we're open for public comment. It's not
Yeah,
open.
apparently they've been on the whole time and have failed to been able to comment yet.
Yeah, they have to type in, I would like to make a comment in the question and answer section.
Yeah, I guess they can't get to the question and answer section even when it's supposedly open, according to the text that I've received.
We'll make sure that that there's
Right.
no issues on our end, and to the extent we can help folks ensure that their comments are heard, we definitely will.
The current language, again, I'm still processing. I'm sure there will be a lot more opportunity for people to weigh in after considering the implications. For the part regarding the criteria by the board may include, but not limited to, for number 3, this was brought up, but I'm not sure explicitly, no close personal, familial, or financial relationship. I think the word financial should be included.
Yeah, that is in the attestations, but it's not in the disciplinary guidelines.
This question, though, in the setting of a solo practice, who is going to pay for a monitor? Or are they going to do this out of the goodness of their heart? And also the insurance implications. This could be a huge financial barrier to a solo practicing midwife moving forward through a probationary process.
And that, I believe that
is my concern. Ruth and Jenna have raised that issue. And I want some kind of clarification, I guess, in terms of when we say independent practitioner, currently, so what happened after passage of SB 1237 and 667 is a lot of the midwives that are currently practicing in a hospital setting, which is why we're having some issues with the shift work wording, are actually employed by the hospital. So now even though they're considered independent practitioners, they're still employed by the hospital. So some of this probation stuff that would happen would take place by the hospital and they would manage it. That's how I'm understanding it, which is why it's like, is this futuristic? Because like in 5 years, are the way we practice and how they're viewed as practitioners, is that going to change? Are the hospitals going to change their guidelines and say, it's confusing in terms of how it applies to current midwives now, because as I understand it, either they are working in a hospital setting for the hospital and employed for the hospital as midwives, and or they're independent practitioners who either have delivering privileges at a hospital, which is when this would apply, and or they have their own private practice where they're practicing in a birth center or doing home births. I did both. So for me, it's that concept of, if I'm at home doing a home birth, who is watching me and how is my supervising physician that I have a relationship with, even though I'm independent, how are they supervising me or doing this disciplinary action?
I guess a good answer to that is this would address current practice as well as future practice. Regulations are typically written in a way that is able to allow for interpretation based on changing laws and guidelines, right? And so we also use a individual review of every single practitioner. It is not a one size fits all. Anytime we do a one size fits all, if it's incredibly prescriptive, that has to be in regulation. We can't do that without that. So if we were to say all nurse midwives that are employed by a hospital must have this type of supervision, that would have to be written into this regulation separate. If we leave it as the independent practitioner can have maximum, moderate, and minimum, and maybe put some guidance within that, then as we're looking at every independent practitioner, we can review what's going on and choose the supervision level that is best for that care. That is why when the placements are done, we get an org chart. You might be the business owner. You might also be the solo practitioner. You might do that. That org chart is going to tell us what the limits are to supervision, because what we're trying to do is allow for the independent practitioner to continue in their practice, right? As it stands right now, if an independent practitioner is put on probation, they would not be able to continue in an independent fashion, right? It would halt it. And that independent practitioner would have to go under specific supervision, which we typically see with our RNs that are not advanced practice and they do not have an independent practice. Now, when you are seeing patients outside of the hospital setting, and we have many independent advanced practice RNs that do this, their work setting varies. You can do home births, you can do a birth center, you can do your own clinic. But again, remembering that this language is written for all 4 advanced practice RNs, that is not specific to the nurse midwife. It is, how can we use this language to help with the oversight of a nurse midwife who may be on probation in the future? Mm-hmm. And so we would do, say they had their own clinic and that is where they practice. Well, we could determine that is maximum supervision. And if that was maximum supervision, maybe at that point, the hospital might not have granted them privileges. Their privileges may be suspended pending their probation, and that can absolutely occur. And that they would then have to be specifically clinic-based, that they would do, prenatal, maybe some antenatal testing, depending on how their clinic is set up. But that because of the egregiousness of the nature, the hospital may have their privileges suspended. And then they would not be practicing that, and we have no authority over that. But we do still want them to be able to have some sort of employment, and that would be their own independent clinic or something to that effect. If the hospital has not revoked their privileges in any way and they're able to go in and continue to practice, that would be part of the setup that would be done with the supervision. And when we're meeting with the nurse midwife, when we're looking at what their work ability is, as well as what their independent practitioner needs are, we would help to evaluate the supervision to ensure that is able to be maintained, but that also public safety, which is the whole entire focus of our BRN, is done. And that practitioner that is checking on them, if it is 100%, if it's the full maximum supervision, that practitioner would have to go with them into not just the patient's rooms in the clinics that they're working in, but they may have to go in to the patient's rooms in the hospital setting, if that's where they're doing it, or participate on site in the home birth, where they're standing there as a witness to what is occurring, if that is something that does continue to need to happen. And that would take a special kind of person that would want to go in and do that. Now, understanding, and I wanted to address one of the things that Jen had said, they do not participate in the patient care. And so they are observers in the patient care that you are providing. At this point, it is not intended for them to take over care of your patients. It is intended to monitor you while you are performing the care of your patients to ensure that that is safe.
So does that supervisor then absolutely have to be a physician, or can it be another nurse midwife?
It could be another nurse midwife. It could also be, if it's a nurse practitioner, it could be another nurse practitioner. If it's a nurse anesthetist, it could be another nurse anesthetist. It is equal or higher.
Okay, because I feel that might fix the issue or that Ruth brought up of that would be extremely difficult to find a physician out of the goodness of their heart who's going to do this without pay, right? That if it would be a fellow nurse midwife or nurse anesthetist, right, on the same level.
Which would still be like a loss of, easily $1,200 a day for the person who's volunteering to do it.
100%.
So my question actually was, is there any mechanism of the BRN providing any of this kind of oversight for this kind of provider? That was question number one. And then sounds like no, which I could have
No, there is not. That would be a conflict of interest for us.
Question
Yes.
number two, I also just want to be really clear that we don't conflate independent practice with solo practice, because I think in the state of California still most nurse midwives are employed actually by a medical group and then contracted or credentialed at the hospital. And then they could be either independent or not independent. And I would venture that most in the hospital are still not independent and probably will not become independent because they care for moderate and high risk folks in the hospital setting. My guess is that, as Lilith said, that as time goes on, we'll see more and more both independent CNMs, but also independent CNMs in solo practice, because community birth settings are where normal, completely low risk, healthy births would be happening that don't require any medical supervision with the new regulatory language. So again, I feel like this is probably going to disproportionately impact the solo independent nurse midwife who's running their own business. And, in the example that Loretta gave, working in a birth center, there's no hospital privileges to lose. There's maybe birth center privileges if they don't own the birth center, but typically they own and operate their practice independently. And so I am going to just state for the record again, I feel like this is really a high bar that is in some ways different than an independent solo practitioner of medicine, given particularly the income to malpractice insurance ratios for a nurse midwife and a OBGYN. So I don't know how to resolve that. I think it is really important that there is a mechanism for maximum supervision of a solo and independent midwife for public safety, possibly in this group more than any other group, given that there is no, culture of safety in a workplace setting with a team. But it's pretty scary. I would be pretty nervous about this as a solo midwife who, I think most would not have income or savings for this purpose.
I definitely understand that. And James, I see your hand again. The alternative is to not be in an independent solo practice, right? And so, although we know 100% that this will have some implications that affect the business aspect of providing the patient care, the way that it's set up right now is that solo independent practice would be halted. There would not be a pathway for them to move forward because of the current requirements above that are not underlined. That is what our current guidelines are. And so at that point, these practitioners that find themselves in this system and working through probation would have to change their job. And that's not something that we would want to see going forward. That is why the necessity of putting those provisions in to allow for continued independent or solo or both practice is necessary, because right now the only path forward would be to not function at the level of the scope of practice that is allowable right now because of the supervision requirements that are currently in, which is why you would have to have this updated process. And so James, we'll move to you.
A quick context. I'm used to we're on WebEx. In other systems, you actually have a little electronic hand. So I'm not impatient. I'm just used to like clicking a button.
That's awesome.
Yeah,
if we opened, we do have a hand raise. If we opened it, all of the public could open it as well. And so we would have everybody doing that, and we can't do that. I apologize.
No, I wanted to just share just in response to both Lilith and Jenna, this is legit. It's a legit concern. I haven't looked at the workforce demographics in a while. I believe the majority of certified nurse midwives in California are actually employed by large orgs, Kaiser, UC Systems, Sutter, and others. If this is it sounds very analogous to what's in place for physicians who are also under probation or review. In large centers, like I'm part of, we actually provide whatever proctoring or supervision is mandated. You know, the institution, the employer does, whether it's a nurse, nurse practitioner, midwife, or physician. That's one of the trade-offs of working for a large employer. You have that in. If you're pure solo, I have known of individual physicians who had the exact same scenario where they're encountering a massive burden relative to all their overhead, to have someone there to meet medical board requirements during probation. Some of those individuals leave that practice and will actually take up employment practice elsewhere. Fortunately, my impression is that that's really reserved for some of the most, I don't want to say egregious, compelling cases where there have been behaviors that put humans at risk, or potentially at risk. And at least this gives a mechanism for someone to continue their business and continue their practice. And if they're working out of a birth center or doing home births without any restrictions, there is the restriction on the ongoing practice side, but at least they still have their independence and they can keep moving forward. Hopefully these are few and far between.
What? Make a comment real quick.
Absolutely, Shannon.
I just want to state that the purpose of probation is to rehabilitate and monitor to ensure that that nurse is capable to have an unencumbered license and be returned back into practice. If their violation is as an independent practitioner, and then probation does not have a mechanism for them to be able to function independently during the probationary period while they're monitored, we're really not accomplishing our goal. Because if we're going to return them at the end of probation with an unencumbered license to go out and then work independently, and we have not monitored them as an independent practitioner, we're really not meeting that goal that we have, hence probation. And so to take them out of the independent setting because they had a violation in practice and then not be able to monitor them in that same setting, that's difficult. So, keep that in mind when you're thinking about language for the disciplinary guidelines.
I think Shannon, you had said that you had reviewed other, scenarios with how it's done in the medical board. What the closest similarity that I can think of is that the licensed midwives are under the medical board, right? for regulation. Most all licensed midwives I know have their own independent practice and either are doing home births or have a birth center or something like that. So they're not working in a hospital under these big organizations. So what is the process for them when something like this happens?
My understanding is they have a person contracted that does this oversight.
Mm-hmm.
And I'd also like to say that, this situation, our guidelines obviously have not been updated for quite some time, and they need to, because a lot has changed over the last 20 years. But again, because nurse midwives, we have such a small, group that has been disciplined. There's been 18 in the last 6 years. And some of those aren't even practice cases. We don't come across the situation a lot where we have difficulty with monitoring them. I think out of those 18, we have had, 10 on probation since 2018. So we don't come across the situation very often, but we do, need language now that, times have changed. We need that language in there to allow for us to monitor someone during the probationary period appropriately.
Loretta, when you said that you are under the impression there's somebody contracted for licensed midwife supervision, would that be contracted by the medical board, or they contract that person themselves as a licensed midwife?
The probation is ran through the medical board. And so they have a process for requiring supervision. My understanding is that supervision is obtained by the licensee and cleared through the med board. And that is then how it progresses forward. And there are businesses out there that I'm aware that I've been recently made aware of, and I was trying to pull it up and find it, where people put themselves out as supervisors of independent solo practice, and they do various levels depending on the need of what the practitioner has and what setting they are. They're supervising physicians. And again, this is mostly physician based, just because we haven't utilized this yet. And so let me see if I can.
I bet you I know exactly which two physicians you're talking about.
Potentially, it is a small world out there.
They have a very profitable business model. It's very intriguing what they're doing. Because it's not just for discipline, it's for like ongoing clinical supervision,
yes.
And you can pay for various levels.
Yep. Absolutely. And it's not just one or two physicians. We're hearing that more and more companies are out there throughout the nation that provide these types of services, where it's like a matchmaker kind of service, where this is where it's at. You go there for supervision. You tell them what levels you need. You tell them what is being required and involved. And then they give you a physician that can meet those needs. And then you move forward. And so always discovering new things that are coming out there. But I would suspect that these types of services would pop up quickly for the advanced practice RN also when this becomes a requirement. And I do see, Kenneth, I see your hand up.
Yeah, just on a personal note, I was a solo practitioner for many years, and then I hired midwives for many years, and then eventually I joined a group, and we've got 30 doctors, and we've got 9 midwives and 4 nurse practitioners. So obviously now any disciplinary action is easy because they've got automatic supervision, and I've done that for, not that any of my people were on supervision, but new practitioners needed monitoring for simple things. But when I was a solo practitioner, I did take responsibility for myself, and I did take responsibility for my midwives. And eventually I joined the group, not just because I was getting older and it was more expensive, but, this is one of the big issues is what if ... And what if somebody needed, or if I needed monitoring, I'd have to hire somebody to monitor me because I don't have any other physician in my practice to do it. So unfortunately, you know, the advantages of being a solo practitioner is the ceiling is endless, but the disadvantage is you're responsible for everything. So that's kind of something to take in consideration when you are a solo practitioner. You have to take the good and the bad. And I've also been, you know, consultant for a private midwife group that had their own birth center. It's dissolved over the last couple of years, but you know, that's also something that luckily nobody was disciplined, but something that they would also have to take into account, that they'd have to hire somebody. And actually the midwife knew that. And luckily they never had to do it. So I know it sounds a little bit cold, but again, your private practice is something so brilliant, your own personal business. And that's something that you have to take responsible for and get all the benefits of it. So, you know, if there's a business that can help, almost like a bail's bondsman that can support somebody, that'd be amazing. But you know, luckily I did join a group, so I am covered. But when I was a solo, I was on my own. So that was just my 2 cents. I know it doesn't solve any problems, but that's it.
Thank you. One of the websites that I found is called collaboratingdocs.com. And it says, attention nurse practitioners matched with a collaborating physician in 14 days or less, or your money back. Our network of over 1,650 physicians have helped over 3,500 nurse practitioners across the country. Get your free quote. Done for you collaboration, supportive, responsive, and committed collaborating physicians, 100% compliant agreement for your state and specialty requirements. Collaborating physicians, malpractice insurance included. Cancel anytime. Monthly rates as low as $600 per month. Physician rates included. Physician malpractice insurance included. Lawyers invoice included. One-time match fee, $500 guaranteed match within 14 days. Says
That's
pricing.
Informational, not an endorsement.
Yes, not an endorsement at all, just an informational so that you guys know that this is out there. Where it does say prices vary by state, specific needs for each individual nurse practitioner. And then they go on and kind of talk about it. They do state that they'll be available during business hours, review at least 10% of your charts monthly, have monthly check-in video calls with you, and fulfill any other specific state requirements. It goes on and on and on. So these are out here. We know that they're out there. We're aware that they're out there. And this is specifically set up for nurse practitioners. I did not come across one for midwives specifically. Just because I knew of this one, I just kind of did a quick Google search to pull this one up. But
that actually sounds more legit than the 2 I know of being used by licensed midwives. Chart reviews. Okay.
So these are out there. We see all types of agreements come in, and that is again why it's always reviewed on an individual basis, right? There are, and as Shannon kind of alluded to at the beginning, there are some cases where a person will make up an org chart, where they will make up a job description, where they will falsify documents that are submitted because they do not want to change what they're currently doing, because what we are requiring them to do is much more restrictive. Or if they're not able to continue in a role, say they were part of a nursing LLC and they were the ownership of a company and they did harm through that company and they're no longer able to continue to do that because they are the top nurse, that maybe they can't supervise themselves, right? This becomes problematic because then we do at this point require them to get a different job. And so we've seen people, you know, change ownership of companies, have their husband or their wife take ownership of the company while they're on probation. There's a lot of different things that occur. And so understanding that regulation needs to cover all 4 advanced practice RNs, and regulation needs to cover all types of incidences that occur. Some of them much more egregious than others. And so just kind of to keep that in the back of your head, that it is not a one-stop shop. And that's why we always do an independent review of every single one.
Just out of curiosity, I think someone, forgive me, it may have been Shannon, mentioned 18 midwives disciplined in 6 years. Relative to the number of CNM licensees, is that proportionally on par with other APRNs?
Well, we have 1,418 nurse midwives currently. So that is, it is the smallest number that we do have for advanced practice RNs is the nurse midwife. And Shannon, you can move forward with that.
If you're looking at licensee population compared to disciplinary action, you're at about 1% or less. So that's on par for all the other APRNs as well.
Great.
It's actually impressive to me because, you know, maternity care is a more high risk endeavor compared to a lot of other aspects of care. So I think that's props to certified nurse midwives.
Yeah, and if you look at all of the complaints and you remove, you know, because a few of them are arrest-based, you know, which could be DUI, one's an out-of-state discipline, one's a battery case. So they're not all practice cases. So if you remove all the arrests, you have even less practice related.
That was actually an ask from meetings back, was perhaps part of our role in this committee in advising on disciplinary could be informed by some sort of kind of running general overview of the issues that are being brought so that we can potentially monitor trends versus one-offs, if it would be possible to have like a breakdown of those 18, what they were all about and what their outcome was. It's probably on the website somewhere.
I also have those. I keep those. I run reports very regularly on all disciplinary actions and including advanced practice. So if you wanted that for future meetings, we could always provide that.
Yes.
And then Shannon, is that included in the board materials when you do your enforcement updates? I know that
we used to include all APRNs in the board materials, and you know, we stopped doing it because other needs were required. But I believe that is something that we can put back in there easily. I keep the stats. I have them all the way. I think when I did the presentation for you guys last year before, I provided all the way back to 2018. So I still have that and I just build on it. So we can continue to provide it. That wouldn't be a problem.
Thank you.
The thing is and just to let you know that last year there were no disciplinary actions in 2003. The only two things that happened were two of the nurse midwives that were on probation did a voluntary surrender of their license, which is one of their conditions of probation that they're allowed to do. So it wasn't an additional disciplinary action. So 2003, we had none. And 2004 to date, we only have one, and that's based on a battery case arrest.
Okay.
Is there any more discussion around this? I do want to open up to public comment. I do have Marissa on board too, where she can kind of share some of the updates that she has gleaned from this conversation. And then Lilith, I believe I saw your hand go up.
I just had a question in terms of, I guess we're, you know, discussing timeline, and someone asked how long's the probation? We said 3 years. Do we need to have language specifically in there for 3 years while we're in that role? Because what happens if someone's on probation for a year and then they decide, okay, I'm going to take a break from this practice, the solo practice, and are they then allowed to, so it's like a twofold question, go work as a registered nurse, say in labor and delivery, instead of a nurse midwife now? You know, they do have that license. How does that work? And then is their probation sort of like paused and then can continue if they decided to go back? I don't know if that's too technical.
It's not too technical, and Shannon will be able to elaborate more. We
Yeah,
do
the
what's
condition-
called, yeah, go for
ahead.
it.
Sorry, Lori.
I was going to let you know that we do job modifications. And so anytime a person changes a job, the board is involved in that process for approving that position, no matter who it is and what role they serve. And then I'm sure Shannon was going to go towards where the probation is applied. And that's the RN license. So I'll let her go ahead and
So the
elaborate.
employment requirement in the conditions currently as it stands, the nurse is required to work a minimum of 6 consecutive months for 24 hours per week. That's minimum. So once they hit that 6 months, 24 hours per week, and there is a May provision in there, so it is flexible still. However, once they're done with that requirement, they can go work in any capacity they choose. However, if they still require an RN license, it would still have to follow the conditions of the employment approval, reporting, supervision, etc. So they can go work back as an RN. And just like with any case, we want them to work in the capacity in which the violation occurred. Because if that's where they're struggling within their scope, we want to ensure they're monitored in that capacity. So if they worked as a nurse midwife for 6 months and a year, they wanted to move on, they absolutely can go work in a different capacity. They just have to follow the conditions as well, still for the approval process. And then, like Lori said, after 1 year of probation, so for a 36-month, 3-year probation period, they're eligible at 1 year to petition the board for modification of any of their conditions of probation. And then at 2 years, they are eligible to petition for early termination. So have they complied with everything during that 2-year period of time, they can go before an administrative law judge to see if they can get that reduced to a 2-year period.
Oh, okay. Thank you for clarifying.
Okay, and Marissa, did you want to kind of update some of the takeaways that you gleaned
Yes,
from this so far?
Definitely. And please feel free to jump in, correct, or add. I was trying to get kind of the main language ones, but there could be some that I missed. So we talked about with clarifying supervision language for minimum, moderate, maximum in regards to kind of using more terminology that's used in practice. So direct supervising patient care would mean more in-room, present in clinical setting would mean more like in the location broader, but not necessarily in the room, or readily available could mean something like off-site. And if it's minimum, clarifying how we are communicating on-site or off-site, not on location, off location. Potentially moving away from the shift verbiage to hours. And then also under the approval criteria, when it talked about not having a personal or familial relationship, potentially adding the financial relationship, which then kind of led into that broader discussion question we've been having around who essentially is going to pay for the monitor and take that kind of burden on, which did come up when we were discussing, and that is why we almost put the financial in there, but then we're like, well, does that create kind of an awkward situation if they are paying? But we think it makes sense in most instances, but we didn't know if that would be restrictive if they were the one doing it. So that is something that I think we're still kind of trying to figure out how to incorporate the best. So yeah, anything else, please jump in and correct me.
Pull off financial in light of what you just shared.
Okay.
Shouldn't be a barrier.
Is there any more discussion at this point, or are you guys wanting to go to public comment and get some further input from the public, and then we'll check to make sure that our public comment feature is working well? Okay, so BRN moderator, can you please open up to public comment?
Public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment.
So on the bottom right of the screen, Jenna, if you're reaching out to people that are unable to, there's a question mark that pops up in a square. And it's next to the little person icon, sorry. And in between the three dots. And so the question button that pops up says Q&A. If you click on that, it opens it up and you can type in what you want to type in. But previously it used to say just Q&A or chat. It doesn't anymore. There is a question box, a question mark in a box that pops up. So they would have to click on that.
I can see it on my side. I think maybe they're not able to see it if they're joining from a phone versus a computer.
Okay, and I know that we've had BRN staff join from their phone to see if this occurs. So it is open. I don't see anybody popping in there. And he is actually letting them know that not seeing the option from the phone.
Oh, she says no question button, nothing via the live stream.
Okay, the live stream. The live stream is different.
Okay, you hearing this? Live stream is different.
Yeah, live stream. So live stream is a service that we contract and utilize from Department of Consumer Affairs, where they share this out to anybody that wants to view it. It is not interactive. So if they want to be interactive, they would have to go to our rn.ca.gov. They would go into the meetings link on the right-hand side, click on the Nurse Midwifery Advisory Committee agenda. And then in that agenda, there's a link to the WebEx, not the live stream.
Okay.
Yeah, and so it says, by computer, please log on to the WebEx via this website. And they click on that. If you have a smartphone and you download the WebEx app, that works seamlessly. If you join using your internet, like Internet Explorer or Chrome, Firefox, or whatever, it might be a little janky as you get in. But if you are using your phone and you download the WebEx app, I've used that many, many times, and it's seamless with this process.
Shouldn't be janky if you're using a browser. If you don't have the app and you're joining from a computer, it'll take you to the browser version, and that also should work fine.
The computer, yes, I've noticed a little bit if I'm using a phone that doesn't have the app and I'm trying to join without using the app, there's a little bit of sizing issues that come up that you might not be able to see everything on it.
The app is always the
Yeah.
cleanest way to go, but the website would work. So if we are getting reports of folks who are maybe switching over from the webcast in order to make comment or continuing to have some difficulties, I might suggest a few-minute break for the committee members to take a break, and also for anybody who's trying to make that transition and be able to make comment, give them a few extra minutes to do that.
Yeah, I think that would work. So let's go ahead and take a break, and we'll continue to kind of test this out because we are not seeing anybody come up in public comment again. Right now, I did have BRN staff. They did a test. It did show through, but we'll continue to troubleshoot that. So we'll come back at 10 o'clock. So that's 15-minute break.
11 o'clock?
Yeah, 11 o'clock. Sorry. No.
It's 10:43 right now.
10:43. Thank you.
She's
in a different time zone right now, Reza. Please forgive me.
Does the meeting go to 11 or 12?
We're scheduled until 11:30.
11:30.
It's 10:43 right now. So Lori, do you want to give 10 minutes or?
We can do 10 minutes and come back at 10:55. I don't have a problem with that. I just know this is the last agenda item. So I was, thinking that we were kind of close to wrapping up, but I could have been not thinking that correctly. So yeah, come back at 10:55, please. Have everybody come back on camera and continue on with the meeting. Okay, so I'll go ahead and do a roll call just to make sure everybody's here. And Jenna? Okay. James?
Here.
Ruth? I'll go to Kenneth. Lilith.
Present.
And then we'll go back to Ruth. I
I
don't
got a
see
text
her.
from Ruth. She's admitting a patient and listening.
Okay. Got it. Okay. I don't see her on the list anymore. She must have jumped off, so she might not be listening any longer as well. So we have 4 on, is that correct? 1,
Yeah.
2, 3,
Jenna, was there
4.
any indication of it? Was it going to be just a second, or does she want us to go on?
No, it was like a weird format via email. She just said she would be listening and she's admitting a patient.
Oh, she said she's listening. Okay.
But we do still have 4, is that correct? So we have 4 of our 7. So we
Yes,
still have
so we still have
majority.
a quorum. Technically, we wouldn't count
Perfect.
Ruth for the quorum since she's not on camera, but since fortunately she's able to listen, she'll at least hear the public comment. And
Absolutely. Okay, so we'll go ahead and open back up to public comment. Board moderator.
Okay, so we are still open for public comment. Public comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
And I'm not seeing Paris pop up. Jenna, is she still wanting to make comment? Because I'm not showing her pop up in the Q&A saying I'd like to make a comment.
I'm not sure.
Okay. Is 805 still showing in the participant list, board
Yes.
She
moderator?
says yes.
Yes.
She's waiting on
Okay.
the phone.
So would you,
It's-
we have no public requests in the comments. Did you want me to do the 805?
Let's leave this open, but yes, put the 805 up. I'm not sure what the,
Okay.
but I know that Paris wants to make a comment, so.
Can you hear me?
Yes.
Sorry, real
Yeah.
quick. This is Reza. Lori, I just wanted to ask, just to make sure we're not missing any public comments as kind of a fail safe, can you give like the NMAC email address in case anybody who's able to hear this is still unable to participate? I think it's nmac. What is it?
I believe it's DC. Let me just pull it up really quick. Macaulay might know it right off the top of her head. We are in Sacramento. Do you have that right there?
Yeah, it's brn.nmac, N as in Nancy, well, NMAC, you guys know what the acronym is, at dca.ca.gov.
Yeah, so that's only for folks who are continuing to have difficulty with public comment. If you are, email brn.nmac@dca.ca.gov. Again, brn.nmac@dca.ca.gov if you're continuing to have difficulty with public comment. I think the issue that maybe it was Paris was having was being on the webcast as opposed to the WebEx, which was sorted out. So, sorry.
Yeah, maybe you guys could link the WebEx directly on that live banner at the top instead of having it go to the DCA's website. That would be easy.
Yep, that is
And
being
yes,
updated.
I'm still on the phone, still not on the WebEx.
Okay, Got it. So that's why you're not on the WebEx. Okay.
Okay,
Yeah.
sorry for the
Yeah.
interruption. I just wanted to make sure that there was a fail safe in place in case there was any other comments. With that, Paris, I'll give you a chance to speak.
Thank you. I appreciate it. Okay. So a couple of things, actually 3 things, 3 comments. Comment 1 is, why do we have to have one umbrella overall way of handling probation and discipline for all APRNs? I don't believe it says in statute that it has to be done this way. And given that our work settings are so different from those of other APRNs, I would like for the board to consider having specific regulations for oversight and probation and discipline for each type, given the different settings. My next comment is that community birth is an important option for people to have. It's important to have access to home birth and freestanding birth centers, but because of our fractured patchwork healthcare system in the United States, we do not have a universal healthcare model. We don't have a national health service as they have in the UK. So there's no safety net in this country for solo practitioners. And I'd be interested in efforts or recommendations by the BRN and other consumer advocacy and protective services to look into creating a model of healthcare in the United States similar to the national health system in the UK, where community midwives are integrated into the overall health system. And I know that there are some individual midwives working with individual hospitals to integrate their freestanding birth centers, but those are few and far between, and the barriers are endless. Maybe not endless, but really difficult. But this would be a solution to probation or supervision situations because midwives would have support from their associated hospital built in. The other thing I want to comment on is the egregious potential transition of UCSF midwifery program to DMP only. DMP as entry level to advanced practice nursing for midwives, where we have a maternity healthcare crisis in California with a huge deficiency in numbers of adequate providers and numerous maternity care deserts and 46 labor and delivery units having closed in the last, I believe, 8 years because of inadequate providers at these labor and delivery units to keep them open. I don't know that there's anything the BRN can do about it, but I look forward to any support we can get to encourage not closing down this program, because they've stopped matriculation as of now because they don't have doctorate-prepared faculty to run the program, and there are not adequate numbers in the state to make that even a viable solution. Those are my comments. Thank you so much. I know you gave me more than 2 minutes. I appreciate you.
Thank you. Board moderator, is there any more public comments on the WebEx?
I guess it helps if I unmute myself when I'm talking. There are no other public requests for comments in the WebEx, and we still have nobody in Sacramento. So would you like me to close this window?
Yes, please.
Macaulay, do we have confirmation that there were no emails sent in from anyone else seeking to comment?
Yeah, you're
I
correct.
have it open on mine.
Oh,
Yeah, there's nothing.
thanks.
Yep. And then just to be clear, I did not receive an email as well to my work email also, which is sometimes I will get that. But nothing right now. Okay, so I know that there was not a motion. There isn't anything right now. It's just been kind of information is kind of going back and forth. So I wanted to make sure that any questions that you guys have, any response to Paris's comment, any questions that you guys want clarified, under Paris's comments, like jurisdiction or anything like that, like we have nothing to do with insurance and billing and healthcare for all. There is a bill that has currently been written and introduced that we are following this legislative session on that, but that is not under the BRN's jurisdiction. As far as provider access, you know, as soon as nurse midwives come in, we license them as quick as we possibly can. We are always looking at various provisions. I definitely am aware of the nursing programs in California. Currently, it is not required that nurse midwife programs are approved by our board. It is an optional approval that some programs do choose. And we are aware that one of the programs has stopped doing any enrollments because of issues stated, various issues stated by that academic institution. But to date, I believe there are only 3 nurse midwife programs in the state of California. And again, BRN does not approve them as a mandate. It is optional and they can get BRN approved if they choose to. I don't know if there was anything more that you guys need clarification. One of the items that she brought up as well was having individual disciplinary guideline sections for each one of the APRNs. That is a possibility. We could go that route, but I wanted to kind of give you the reason why the suggestion was put forward. And Marissa and Shannon, you guys could jump in and add to this if I'm not capturing all of them. Is these disciplinary guidelines are used by the judicial system, not by us only. And these are guidelines that a judge will use, again, not by us only. And they see many, many, many different types of people, many different licensees. And they are not only going to be utilizing this for nurse midwives. And so they do utilize these sections of our disciplinary guidelines for all people involved. And with that said, employers, worksite monitors are all very similar also. And so having one set of rules for each APRN independent practice, each RN, and doing it that way makes it very difficult. And when we're looking at the area of public protection, it's not about what the board imposes, it's about what the public can carry out. And so you want the judicial system to be able to look at it and follow it with ease. You want your employers to be able to look at it and follow it with ease. You want your worksite monitors to be able to look at it and follow with ease. And you want the people that are working with them to have a basic understanding of what they are doing so that if there is issues there, they know how to report it and what to expect. And so when you get into things that are very scripted and individual, then you have people that are not confident that they know what is required based on a license, right? So if you put out to the public that it's an advanced practice that has independent practice, then your RN community that's working with them, your physician community that's working with them, your RT, your social worker community, that's one thing that they can, when they're working with them, say, you know, it looks like everything's still on the up and up. Or if they know that this person is on probation, they can say, you know, I've seen other probationers do this and I don't think that this is correct. And so it's about really taking the village to help to ensure public protection in addition to us. And so when you break it out and you do all these different tiers and different layers, it really takes away from that aspect, which is why as the BRN, when we were looking at this language, we wanted to make it as simple and as universal as possible so that it doesn't take a RN or an APRN or an APRN specialty focus to be able to understand what is required. That you really wanted the public to understand that what is required too, so that we can all kind of work together. So that's kind of why we went for the kind of combo. But I will open up to Shannon and Marissa to see if they had anything more to add to that. And then we can go back in and have further discussions in the next, you know, we have 18 minutes before our committee meeting adjourns.
Laura, I just want to state, so all of the conditions of probation, if you look at them, everything except really for maybe courses based on the violation and the employment, they're all very standard across the board, regardless if you're an RN or an RN with advanced certifications. And so therefore, you want to keep it so we have that whole, and maybe just pull out those portions to specify each advanced practice. The other thing too, and Lilith touched on it earlier, is if they want to go work as an RN, you need to be able to address that within their disciplinary guideline conditions as well. So you want to keep them flexible enough where it'll cover, because in reality, it's their RN that's on probation and then any advanced certifications attached to that. So we have to make sure that we have the RN on probation and we can address that appropriately, as well as if they're going to be working in an advanced practice role or obtain any advanced practice certificates after they become on probation. So we keep that language flexible. So if they do want to go back as an RN in that scope and not go as, a nurse midwife or nurse practitioner, they have that capability, and we still have that capability and flexibility to monitor them in those capacities. So I think just pulling out those specific sections and adding pieces to it that will address those advanced practices will allow us to keep our disciplinary guideline standard across the board for drug testing, therapy, mental health, physical, complying with the program, our tolling if they move out of state. Those are all standard.
I would like to make a motion to revisit this at the next meeting with a new draft to reflect the changes outlined previously by Marissa.
I think that we can absolutely do that, but I will share with you what the process will be.
Oh, okay.
So this is agendized for the NPAC meeting immediately to follow as well, right? And the plan is to put this forward to the nurse practice committee next month. And so we will have input from NPAC. We will have input from the nurse practice committee. And depending on where we are with language and stuff like that, we will get you back a document of language that has gone back through a couple further reviews. So it's not going to be just your review. So we'll definitely bring it back forward here and let you guys know where we're at as we move through this process. The regulatory process is intense, and it is tedious, and it takes a very long time. So we will continue to move. We have taken your information in, and it was valuable. It was great. So we'll get more information from the Nurse Practitioner Advisory Committee immediately following this. And I think that you guys made good headway for them to take a look at it as well. And then when we bring it to Nurse Practice Committee, we will let you guys know as well if there's any input from them. And so then at that point, more people will have had eyes on this, and we'll bring it back to you guys. Absolutely. But I just want to make sure that you guys know that it's a group effort, and there will be other sets of eyes on this before it comes back to you guys.
Fabulous. The other thing that I was thinking is I'd really like to follow up on Paris's comment about the UCSF program. I believe there's only 2 currently nurse midwifery education programs matriculating students. And I know one of our ed subcommittee members was missing, but I wanted to bring up an idea from our last meeting, which was to consider having a current or former nurse midwifery educator on that committee, especially if one of them would be interested in taking over the public engagement committee, which now has no members. And I would volunteer if that was be helpful, and would also recommend, I think Kim Doe, the program director from UCSF, is on the line right now. I think she'd be really potentially interested in talking with the education subcommittee. So I don't know if that's just a comment or if I need to make a motion, but I think that it'd be interesting to look at the impact on nurse midwifery in California with dwindling program spots.
So we do have the subcommittee that you were talking about that's specific on education, they can reach out to that subcommittee. The subcommittee can reach out to whoever they want as well. So it does not have to have a vote through us. It doesn't have to have even anything through us at all. So that education subcommittee can meet with and utilize any subject matter expert that they choose to. They will not be a member of the committee. They are a subject matter expert that is being consulted by the specific subcommittee of the Nurse Midwifery Advisory Committee. Subcommittees are made up of the advisory committee or the committee that they're tied to. And unless this person wants to join our NMAC and take take Mary Kay's position, they wouldn't be a member of it. But we will be recruiting for a nurse midwife to join the Nurse Midwife Advisory Committee. And we'll have details that go out on our website for that. So anybody can choose to join that as soon as possible. Now, with your comment, Jenna, about being willing to work on the nurse midwife education, at this point, you could not, because then that would establish more than 2 people in that education subcommittee. You are on the Nurse Midwifery Scope of Practice Committee. And so your unnoticed meetings essentially has to be just within that specific area, or we would be in potential risk of violating any Bagley-Keene provisions that constitute when you have a majority. So I just wanted to kind of put that out there, but no motion that's needed, but I do want to make sure that our public commenter that is on has the ability that if they want to reach out to the committee members of the Education Committee, which would be Rebecca DeSantis and Dr. Kenneth James, that would be welcomed. And that Rebecca and Kenneth could reach out directly to them as well. And that we will be putting a posting up to recruit the Nurse Midwife Advisory Committee member. And if they are interested in joining, we would love to have them complete the application and be put in there as the other members for consideration. But we do have Jenna's motion, which is to accept this with the amendments that were suggested and then bring back the updated version to the next meeting. Do we have a second? Okay, Kenneth, thank you. We did already do public comments, so we can go to a roll call vote. And so at this point, Jenna?
Aye.
James?
Aye.
Is Ruth able to join yet? I have her on attendees. Okay. Kenneth?
Yes.
And so we have a 4-person vote on a 7 committee, so majority does carry. And so we have, oh, you can't. Oh, it's Lilith, thank you. I'm so sorry.
It's okay.
And that was an aye vote, is that correct?
Fine. Yes.
Thank you. So we do have it. It has passed and agenda item 7.0 is complete. So we can move on to agenda item 8.0, which is adjournment. If they want to progress that forward, potentially. It doesn't show it on the PowerPoint that we're at adjourned, but we are at 8.0 adjourned. So disregard the PowerPoint at this point. Thank you guys for everything. We are adjourned and we will keep in touch and see you at the next committee meeting. Lilith, your hand went up, sorry.
Yeah, I'm not sure if the next meeting for NMAC is set. Do we have a set date?
I know that Macaulay was working on getting it scheduled and had sent some emails out. I don't know if we got the full quorum yet. It looks like it is scheduled for September 24th. So it looks like she did get that back. So September 24th is the next Nurse Midwife Advisory Committee meeting, followed by the Nurse Practitioner Advisory Committee meeting.
Okay. Thank you.
Okay. Awesome. Thank you, guys.
Thanks, everybody.
Thanks, everyone.
Bye.